Do epidurals work? Today I'm going to talk about the most widely cited meta-analysis on whether epidurals truly help for spinal conditions. Before we get into the numbers, I will define an epidural. An epidural is a steroid injection that is performed for nerve pain. This nerve pain is also known as radiculopathy or sciatica. The most common cause of radiculopathy in young and middle-aged adults is a herniated disc. This type of bulge presses on a nearby nerve. But for older adults, age 50 and up, spinal degeneration is actually the most common cause of radiculopathy. Think of disc height loss, arthritic bone overgrowth, ligament swelling. Disc herniations and spinal degeneration take up space and can press on nerves. This nerve compression in turn causes the classic sciatica pattern of shooting pain into the buttocks and the legs. That's where spinal epidural injections come into play. Epidural steroid injections combined with a numbing anesthetic agent are used to numb pain and reduce inflammation at the site of the compressed, damaged nerve. That's the theory anyway. But the question is, how well do epidurals really work? Do they reduce pain? Do they improve function? Do they help avoid surgery? Let's start with pain levels. This meta-analysis assessed the pain levels across 4 general time periods: an immediate time period, 5 days to 2 weeks after the injection, a short-term period between 2 weeks to 3 months post-injection, an intermediate period, 3 months to 1 year, and a long-term period beyond 1 year from the time of injection. Pain was assessed using a 100-point scale. 100 is the worst pain and 0 is no pain in this scale. The outcomes showed modest results in the immediate and short-term follow-up groups. The immediate group reported a negative 7.55 effect, and a short-term group reported on average a negative 3.61 effect. There were no pain reductions beyond the 3 months reported on average. Here's the key thing to keep in mind. These are very small pain benefits. Because a 100-point scale was used, a reduction of negative 7.55 is less than a 10% pain increase. In clinical medicine, we typically use a 10-point scale. Converted over to such a scale, a pain level of 10 would reduce to a 9.2, or a pain level of 9 would reduce to an 8.3. It's sort of bizarre because I've never heard a patient report, "Thanks doctor, my pain reduced from a 10 to a 9.2. And keep in mind, there were no benefits beyond 3 months. Here's how the authors of the study describe this outcome. Epidural corticosteroid injections for radiculopathy were associated with early improvements in some outcomes versus placebo interventions, but effects were small and unsustained, and epidural corticosteroid injections had no clear effects in patients with spinal stenosis. The effects on function were even smaller. In the first 2 weeks, there was a minimal and insignificant improvement that was gone by 3 months. While epidurals are often positioned as a treatment that can help you avoid a spine surgery, the numbers don't support that impression either. Harms. This study also looked at the reported harms of epidurals. The data suggests that serious adverse effects are possible but rare. Of 2,912 participants across 30 studies, 1 serious adverse event occurred, a large bleeding event. However, harm levels are almost certainly underreported. Minor adverse events such as local hematoma, bleeding, return of blood, and dural puncture were more common. So what should you do with this data? You would think that, based on what I've said, that I would never refer a patient for an epidural. I would say that is directionally correct, but in reality, I have observed a small subset of my patients who report benefits that far exceed the clinical data. Here's what I suggest. 1, if you have radiculopathy from a disc herniation, you are a candidate for an epidural based on conventional spine practice. 2, if you have spinal stenosis, the data suggests that your nerve pain is very unlikely to attain any meaningful benefit. 3, if you have had significant and extended pain relief from an epidural in the past, you may consider using it for relief. In my interpretation, your individual response means more than a population-level study for the effect it has on you specifically. 4, if you are using an epidural for diagnostic reasons, seeing if you gain relief at a particular site, that may have value for pre-surgical planning. 5, if you've had epidurals in the past with no meaningful gains, I generally disagree that trying more often will result in a breakthrough. 6, this injection is almost always elective and has only a small risk of catastrophic harms. So it's not never. I find the enthusiasm for these injections to be in excess of the clinical outcomes that the epidural produces in most patients. I disagree with the common practice of certain insurance companies requiring an epidural before greenlighting a surgery. This meta-analysis indicates that this gatekeeping practice for epidurals is in fact not evidence-based. If your epidural response is not impressive, you didn't fail. The outcome for this procedure is generally unimpressive. Not nil, but approaching it. In parting, I'll let the author summarize. In conclusion, epidural corticosteroid injections for radiculopathy are associated with immediate improvements in pain and might be associated with immediate improvements in function, but benefits are small and are not sustained, and there's no effect on long-term surgery risk, unquote. I'm Dr. Jim, helping you decode the spine one concept at a time.